Hold me close before the break come. Until you're done with running, I'll be patient. 'Cause I know you'll be there. And I never had a plan for this. Everything is what it is. You never hold me back in anything. You didn't even have to try. I made up my mind, and I know you'll be there. With just one touch, you take me there. Without your love, we go nowhere. With just one touch, you're always there for mine. You take me there. When waters run, you will still be there. Your love, you're always there on the side. We go nowhere. With just one touch, with just one touch. When the tide's all out and you're neglected, it's okay if your river's running dry. Flips 180 when you least expect it. So just don't you cry. And I never had a plan for this. Everything is what it is. You never hold me back in anything. You didn't even have to try. I made up my mind, and I know you'll be there. With just one touch, you take me there. Without your love, we go nowhere. With just one touch, you're always there for mine. You keep me there. When waters run, you will still be there. Your love, you're always there on the side. We go nowhere. With just one touch, with just one touch. Hold me tight.
Welcome to the 2020 Hypertension Control Summit Series. This event has grown exponentially since year one in Houston, to a statewide event in year two, to a virtual series in year three. This movement has become stronger due to the ongoing commitment of the leading organizations, and it's grown deeper due to the participation of every organization engaged today. My name is Allison Smith, and I'll serve as your MC today. It's my pleasure to guide you through an exciting agenda of learning and sharing, leveraging the powerful potential of self-measured blood pressure. In my role as Program Director for Target BP, I have the privilege of working as part of both the American Heart Association and the American Medical Association team toward our shared goal of improving hypertension control. On behalf of the American Heart Association, the Texas Department of State Health Services, the American Medical Association, and the Texas Cardiovascular Disease and Stroke Partnership, all of which helped design this summit series, I want to thank you for being here today and for contributing your efforts toward this same goal, which has motivated and engaged so many health leaders across Texas. We are marching toward our hypertension goal of greater than 70% across the state, and each of you plays a key role, one patient at a time. For a bit of housekeeping, everyone except for the speakers will be muted to manage background noise. Of note, there is closed captioning available at the bottom by clicking the CC button in your control bar. We do really want to engage people in using the chat function as opposed to the QA function throughout the event. We really invite your comments and questions. And to get that virtual dialogue started, I would invite each of you to introduce yourself in the chat with your name, your organization, and just a quick comment, whether your organization is using self-measured blood pressure monitoring during the pandemic, whether it's increased, it's decreased, it's stayed the same, or maybe that's not quite part of your current practice yet. So again, I would encourage you to share your name, your organization, and a thought about your SMBP practice as we get started here and create this community of learning. As the agenda unfolds, we invite you to share your comments and ask questions on an ongoing basis. A team will be responding to some of those questions in real time in the chat, and others will address in Q&A as our time permits. This webinar is being recorded. It'll be posted on the Texas Hypertension Control Summit Series webpage and then emailed out to registered participants. As a reminder, you'll be seeing slides and the presenter, and you can use the slider bar in between the speaker window and the slide window to adjust the relative size if you want to zoom in on some more dense slide content. So to start us out today, I'm happy to introduce leaders from each of the 4 hosting organizations, each of whom will make a few brief remarks as we get started. And I'm going to begin with Dr. Eduardo Sanchez. Dr. Sanchez is the Chief Medical Officer for Prevention for the American Heart Association. Before joining AHA, he served as Vice President and CMO for Blue Cross and Blue Shield. There, he focused on worker and work site wellness, clinical prevention, and chronic disease management, particularly diabetes and cardiovascular diseases. And from 2001 to 2006, Eduardo served as Texas's Commissioner of Health. And in that role, he oversaw statewide public health, public mental health, and substance use disorder programs. And he also serves on numerous national boards and advisory committees. Eduardo, I'd ask you to unmute yourself, and the virtual stage is yours. And welcome to turn your camera and your unmute.
Welcome, everybody. I'm so pleased to be a part of this. I'm hoping, and I'll let you give me a thumbs up, Allison, this is where I'm going to share a handful of slides to tee things up. Good. It is particularly exciting for me, having served as a commissioner of the Texas Department of State Health Services in the past, of partnering with DSHS and others, AMA and others, to improve blood pressure control in the state of Texas. Next slide. So it's particularly exciting to be a part of the Texas hypertension control movement to achieve greater than 70% hypertension control across Texas by the year 2024, and to be a part of this series where we want to bring together smart people and people who are doing work to strategize about how we're going to go about collectively getting to that place. The value proposition is inarguable. Just the number of heart attacks, strokes, and deaths that we could reduce by getting blood pressure control at a better number is more than compelling. This is a multi-part series, and this first part is a roadmap for leveraging the power of self-measured blood pressure to improve hypertension control in all populations. It couldn't have come at a better time because we are learning how we are going to go about providing care in a different way in this time of COVID. Next slide. This is a bit of a timeline that shows that we launched the statewide movement in 2018. We've established regional collaboratives, resources, and sharing capacity, and we hosted a 2019 summit. The impact of regional collaboratives has grown, and I'll show that in a moment. And here we are at the 2020 summit, at least the kickoff of this summit series. Next slide. You can see here a map of the great state of Texas. Also, what you can see here, for those of you who don't live in this state, every single one of these regions is the size of any number of states or larger in the United States. And here we've got 9 Texas hypertension regional collaboratives that are doing the work that I talked about earlier, and that we're going to talk about a little bit more as we go along. Next slide. As we look at the work that's been done in those collaboratives, this is data from 2019, and I'm going to ask you to look at the performance rate column, where what we see is that there's some opportunity to do better, to at least get us up to 70%. In a couple of other places, I'd say 70% clearly not a bold enough goal, and whether it's North Texas or the Rio Grande Valley, at least as it pertains to blood pressure control, there's opportunity to move the needle even further beyond 70%. And in the other regions, there's opportunity to get it up to 70% and beyond. We compare favorably as a state to all healthcare organizations in the United States, but you know what? I'm never happy with being a Texan. I'm never happy being comparable to. I prefer to be ahead of, in the right categories. Blood pressure control would be a right category for us to be among the top 10, if not the number 1. Next slide. This is the time of COVID-19, however, and one of the things that I did this morning, as I have been wont to do for several months now, is that I went and sort of got some updated numbers. I'm sure those of you on the call are aware. Globally, we are very close to, we'll be at 22 million cases by the end of the day. We are over 750,000 deaths, approaching 800,000 deaths globally. I think more dishearteningly, the United States continues to lead in numbers of cases in the world. We have 25% of the cases at 5,455,100 or so. And we have 22% of the deaths globally in the United States at 170,451. When we zero in on Texas, Texas has the third largest number of cases in the United States at 569,058 as of this morning, and 10,559 deaths, putting us at number 4. Those are two categories where we'd like to be lower. Those are absolute numbers, so we would be high up. We're not doing too well from a case fatality rate and or from a incidence rate. However, we could be doing better. Next slide. No, stay right here. So one of the things we noticed early on as we were watching what was going on with COVID-19 in China at first and then in Europe was that there were underlying medical conditions that were associated with an increased risk of severe COVID-19. The CDC has modified their language a little bit to say that people at any age with the underlying conditions on this list are at increased risk of severe COVID-19. The ones in red are the ones that I think are germane to anyone who's doing blood pressure control. Obesity is are at risk, increased risk. Type 2 diabetes, which is fairly high prevalence in the state of Texas, particularly the southern part of our state, but really throughout. And then serious heart conditions, which high blood pressure is often associated with heart failure and coronary artery disease at the very least, and cardiomyopathies as well. Next slide. The next slide is germane because this is the list of conditions that puts people might be at increased risk category. That includes cardiovascular disease, hypertension, smoking, and type 1 diabetes. So I think it's important in this time of COVID to understand these are patients who are at increased risk. These are patients who are going to benefit from our being engaged with them. And these are patients where thinking about how to provide care in a way that doesn't increase the risk of them contracting COVID-19 is critically important. Next slide. One of the other sad awarenesses that have come from, and that's my word, that has come from COVID-19 is the disproportional burden of morbidity and mortality that has been associated with COVID-19. And if we look just at mortality, and these data are about 4 to 6 weeks old, African Americans have an almost 4 times as high mortality rate. Indigenous people, that is American Indian, Alaska Natives, 3 times as high. Pacific Islanders, 2.6 times as high. Latinos, 2.5 times as high. Asians, 1.5 times as high. I believe if we were to look at Latinos right now with what's going on, particularly in South Texas, which is really driving numbers, that 2.5 may be a little bit higher. Next slide. Somewhat coming back to Target BP in a very significant way, it's been clear to us that hypertension is one of those disproportionately born conditions by certain race ethnicities, particularly African Americans. And you may be aware that last week, the Target BP, AMA, AHA hosted a webinar about race ethnicity data collection, how to do it better and how to use that information better. And I think that that's very much a part of how we should think about the work that we're going to be doing through our work here in Texas. Next slide. And I think this is my last slide, which is to remind us all that this is the first of many symposia. And you can see the list. You'll be able to look at it later. We're starting now in August. We're going to end in December 3rd with a celebration of the progress that we've made. I think I'm back on December 3rd. I was hoping to tee things up with some key information. You're going to hear a whole lot more about self-measured blood pressure monitoring. And so with that, I'm going to hand it back to you, Allison. Let me say one thing. There's a lot of staff that helped put this together. The people who are participating put some work into putting their presentations together. And so I want to thank them, and also want to thank those of you who are calling in and are going to be part of this summit series over the next few months. Allison, back to you.
Dr. Sanchez, thank you so much for framing our longstanding focus on hypertension control and health equity, and highlighting how the pandemic has created greater urgency around our work. As we say, now more than ever do we need to focus on hypertension control. Next, I'd like to introduce Jessica Hyde as a representative of one of the other co-hosting organizations. Jessica is the manager of the chronic disease branch at the Texas Department of State Health Services. She oversees a team of subject matter experts who design and implement primary, secondary, and tertiary prevention programs for a variety of chronic diseases, including Alzheimer's disease, asthma, cancer, and cardiovascular disease. Jessica, if you could unmute yourself and turn on your camera, we would invite you to the virtual stage.
Good morning, everybody. Again, my name is Jessica Hyde, and I'm the manager of the Chronic Disease Branch at the Texas Department of State Health Services, or DSHS. And so on behalf of DSHS, I would like to welcome you all to the kickoff of the 2020 Texas Hypertension Control Summit. We are delighted to continue our partnership with the American Heart Association and the American Medical Association, as well as the Texas Partnership on Cardiovascular Disease and Stroke, to expand our collective efforts to improve hypertension across the state. Heart disease and stroke continue to be the first and third leading causes of death among Texas adults. Hypertension is a chief risk factor for both conditions and is implicated in 75% of heart attacks and strokes. More than 1 in 3 adults in Texas have been told by their doctor that they have high blood pressure. The prevalence is even more pronounced among Black Texans at 1 in 2 adults. That is 1.5 times greater than the general population. And these statistics fail to estimate the number of people living with high blood pressure, but who aren't aware of it. And CDC estimates that about half of adults with hypertension do not have it under control. And so as you will hear today and throughout the webinar series, DSHS continues to work with partners, health systems, and community organizations to address these alarming statistics. We look forward to the conversations and next steps that result from this series of webinars. And before I close, I would like to thank the American Heart Association, the American Medical Association, and the Texas Cardiovascular Disease and Stroke Partnership for their continued support, dedication, and vision in putting together this webinar series to maintain the momentum of the hypertension control movement in Texas. Thank you.
Jessica, thank you so much. I really appreciate your ongoing support and the many things that you do to create an ecosystem across the state that helps us focus on hypertension control. Next, it's really my pleasure to introduce Leon Gerals, who's wearing his hats both as chair of the Texas Cardiovascular Disease and Stroke Prevention Partnership and the director of clinical quality improvement for Kelsey-Seybold. Leon joined Kelsey-Seybold in May of 2008 and is currently director of quality improvement. He has oversight of patient care, coding compliance, and the patient experience. He is a licensed registered nurse in the state of Texas and holds degrees in nursing, biological sciences, business administration, and healthcare administration. His professional experience spans behavioral, public, acute, and ambulatory care, and his special interests include enhancement of cultural competency in healthcare delivery, integrating information technology in the continuum of care, and balancing costs without sacrificing the overall quality of care. Under his leadership at Kelsey-Seybold, the clinic became the first system in the nation to be accredited as an accountable care organization by NCQA. Leon, I invite you to unmute yourself and turn on your microphone and join us on the virtual stage. Thank you.
Good morning, everybody. I would like to first off say thank you and welcome to this awesome virtual summit. I have I've had the pleasure of being part of the Texas Cardiovascular and Stroke Partnership for about 6 or 7 years now, and I have been the chair for about a little over 3 years now. So I have seen some growth and I have seen some adaptation. Um, with that saying, it just being part of this summit and seeing how it has evolved just makes me all giddy inside and makes me feel good overall for all the information, the good knowledge that will be passed on today and has been passed on in the past. Next slide. Just to kind of go over what the partnership is and how the partnership has kind of entwined itself in the evolution of the Hypertension Summit series. The partnership basically is a networking of those individuals who are either the frontline staff, the educators, or those that provide social services for the prevention and treatment of cardiovascular disease and stroke. We come together and we assist the Department of Health to determine what our focuses and goals are for the overall heart and stroke plan that they put out. And I think it is during the cycle that I can't remember what the exact cycle is, but we help and assist them in providing realistic quality initiatives, determining where the care gaps are. I think what makes this the most valuable asset is that these are the individuals that are providing the services. These are the individuals that know the barriers and have experienced the setbacks and know where the focuses need to be set at. So as a networking group, we provide education as well as a voice into the design of the overall provisioning of care that is guided and provided by the state when it comes to cardiovascular disease and stroke. Next slide. These are just some of the annual activities that we've done. Our Texas Check Your Blood Pressure Week, that's something that we set out a couple years ago. But I think what I'm most proud of is that we did one of the first Texas hypertension conferences back in 2017. That's kind of how we saw what the AHA was thinking about creating and thought that this would be an awesome situation to be able to combine our efforts and provide and use our resources to provide as much education, provide as much knowledge as we can as a joint effort instead of the individual projects. So we've been going strong at this right now since 2017. I can only see it growing and growing more and being more beneficial to Texas overall. Next slide. This is some information. If you're interested in joining the partnership, you can reach out to either I or Melissa Lambert from DSHS. And if you're interested in joining, we'll be more than happy to invite you into the partnership. But above all else, normally I'm very long-winded, but my 9-year-old has taught me the importance of being quick and concise. So once again, I just want to say thank you and just hope you share in all the joy I'm getting out of this virtual series and about all the education and good knowledge that will be passed on throughout this virtual series. And thank you and welcome.
Leon, thank you very much. I appreciate your leadership on many fronts, and a dose of giddy would do us all some good at this point. Last but not least, I want to introduce Dr. Mike Rakotz as the fourth of 4 organizations co-hosting this event. Dr. Rakotz currently serves as Vice President of Health Outcomes at the American Medical Association, where he oversees efforts to develop and implement national quality improvement initiatives aimed at improving blood pressure control and preventing type 2 diabetes. He is AMA's clinical lead for Target BP, as you know, a nationwide multi-year collaboration with the American Heart Association to reduce the number of Americans living with uncontrolled hypertension. Dr. Raycotts, if you could unmute yourself and turn your video on, the virtual stage is yours for some introductory remarks.
All right, great. Thank you, Allison. And like Leon, I'm going to try to be as brief as I can because you'll be listening to me and we'll be talking for the next 30 minutes. First of all, on behalf of the American Medical Association, I just want to say thank you for letting us participate in this event. This is our 4th year in a row coming to Texas, whether it's in person or virtually, to work on blood pressure control. And we love coming to Texas. We love working with the state of Texas and trying to improve blood pressure control. We work all over the country and we participate in many collaboratives, but we really, we've seen the collaborative nature of what's going on in Texas for hypertension control, and it's been really exemplary. The work that we've had the chance to participate and collaborate on with you all on hypertension control in Texas has really been a pleasure. Seeing that kind of collaboration that is something that we don't see in other parts of the country in the same way. So we're excited to be back. I'm especially excited to be talking about self-measured blood pressure monitoring or home blood pressure monitoring as a strategy to improve blood pressure control. This is something that the AMA and the AHA and all of the organizations here today putting on this meeting have been working on for years. And again, given the current situation with the pandemic, there really hasn't been a more important time for blood pressure control, and there certainly hasn't been a more critical time for using out-of-office blood pressure measurements. And we'll be talking today mainly about the new AHA, AMA policy statement on self-measured blood pressure monitoring. So I'll stop there so that we can proceed with the event. Again, thank you all for making the time to attend, and we really value your participation and allowing us to participate in this effort. Thank you.
Thank you, Dr. Raycotts. I want to thank all 4 representatives of our host organizations for your welcome remarks and really your ongoing leadership and commitment to this movement. It's been a great start for our event today. Next, I'm going to ask Dr. Raycotts to change hats and continue from representing the AMA as our host organization to being a subject matter expert really on this next topic and share more about the new joint policy statement from the American Heart Association and the American Medical Association on self-measured blood pressure and monitoring at home. So Dr. Raycotts, I will ask you to turn your mic back on and your camera back on and walk us through this exciting new statement. Thank you.
All right, thank you, Allison. And if we could go to the next slide, please. So I'm gonna spend probably around 20 minutes walking through the joint statement that Allison just mentioned on self-measured blood pressure monitoring. This is a statement that came out recently that really is a state-of-the-art review. It's a policy statement, but we wrote it like a scientific statement. It reviews up to date it's the most recent evidence review that's out there that covers all aspects of self-measured blood pressure monitoring. And although it's 18 pages long, the content is much less than that, and it's very readable. So I highly recommend, if you haven't, take the time to read this document, and it'll be worth it. It's also a reference document based on the different topics that we'll review today. I'm just going to do a brief summary of that. Next slide. Thanks. I have no disclosures, and on the next slide, we have 2 very simple objectives today. One, I'm just going to very briefly talk about trends in cardiovascular disease, mortality, and blood pressure control, and then we'll go straight into the joint policy statement on SMBP. Next slide, please. So I think it's very important to take a look at the big picture, and this is something that this is really the ultimate goal: reducing deaths due to heart attacks and strokes, deaths due to cardiovascular disease. This is broken out into men and women in the United States, going back to the 1980s, and you see that we, starting in around 2000, had a significant drop in deaths from cardiovascular disease that was fairly dramatic over a decade. From 2000 to 2010, we saw a dramatic decrease in the number of deaths due to heart attacks and strokes and cardiovascular disease. But since 2010, we've seen a slow increase for men more than women, it's not so slow, but we're starting to see a reversal of that trend. And this is very concerning, given that we have the medications, we have the technology for invasive procedures, and interventions. We really should be continuing to improve, but we're not. And there's a lot of reasons for that. I want to show on the next slide that around the same time that cardiovascular disease deaths were improving, we saw a significant improvement in blood pressure control over that same time. I'm not saying that the improvement in blood pressure control was the sole reason, because it wasn't, but it was certainly a contributing factor. In 1999, we were close to a 30% blood pressure control rate. By 2010, we were up over 50%, where we stayed for the next 4 years. But since 2013, we've now seen, for the second full NHANES data set, a drop in blood pressure control. So we were at about 54% control, including all of those in the United States with hypertension, diagnosed or undiagnosed. We went to 48.3% in 2015, 2016, and now at the end of 2018, I extrapolated this publication, so this is modified by me, to go through the latest data that just came out for 2017 through the end of 2018, and blood pressure control is a little below 44% now. So just pointing out, this is all pre-COVID-19 pandemic, but we're starting to see now that a 2 NHANES data set decrease in blood pressure control is very significant and concerning. And next slide. And as Eduardo mentioned, here we are in the midst of a pandemic, and hypertension seems to be a major factor we don't exactly understand all of the associations with hypertension and COVID-19 and what they mean, but perhaps most important, we hear all the time about the first wave, and this is from a paper that was published in the first edition of the American Journal of Preventive Cardiology. I have the reference listed here, but what I like about this, and realize these waves are not to scale. The first wave is acute COVID-19 morbidity and mortality. So deaths from contracting COVID-19, having the virus and developing significant symptoms and death. And you see that we're probably tracking towards about 300,000 deaths for this year. Hopefully it will be less, but that's what it's looking like right now. And then there's the second wave that's already started. How many people have died or are going to die because they're not seeking treatment that they need for acute heart attacks and strokes and interventions because of concerns over going out and risking contracting COVID-19. So that's the second wave. Again, not necessarily to scale. We don't really know how big that wave is. And the third wave is perhaps the most concerning in my mind is, we don't know what's coming for those that stopped receiving primary care and preventive care for cholesterol management, diabetes management, hypertension management. And this third wave could end up being the area under this curve could be the biggest of them all. We don't know how long it's going to last, but there will be significant ramifications from this. And so this is a little bit different than the first wave of the virus and the second wave of the virus that we talk about. And I think this is if you have time, this is an excellent paper that summarizes this topic. Next slide. Thanks. So this is, again, this is many years in the making, written over a year. This is really a reboot of a paper that was published in 2008 by several organizations, including the American Heart Association, the American Society of Hypertension, the Preventive Cardiovascular Nurses Association in 2008 by Dr. Pickering. And it was a call for increased use and coverage of home blood pressure monitoring or self-measured blood pressure monitoring. That was in 2008. We tried to redo, we've been trying to rewrite this and make it a scientific or policy statement probably for the last 5 years. And we finally, the AHA, with support of the AHA and the AMA, we were finally able to write this, more than 10 years later, updating all of the evidence that's changed significantly. I think there's been some major studies on the importance of self-measured blood pressure monitoring and the effectiveness and the cost effectiveness. And that's really what this paper is about. So again, just another plug for actually reading it or using it as a reference. It's written for that and outlined for that very effectively. Next slide, please. So some of the key takeaways, and I'm not going to review all of them, but these are each sections of the manuscript. You know, there's an overview, key takeaways for indications for using SMBP, techniques and device accuracy, effectiveness on lowering blood pressure, cost effectiveness of using SMBP compared to office blood pressures and managing high blood pressures, barriers to widespread use and coverage and payment. And again, by no means are these all of the sections, or will this be a substitute for actually reading the paper, but I'll try to give you some of the key takeaways in the next 15 minutes. Next slide. Thanks. So really, you know, the framing of this is that the diagnosis of hypertension historically has been based on office-based measurements. And we know that there are some significant problems with that. There's technique-related errors, equipment-related errors, and what happens to people when they go into a doctor's office. Their blood pressure typically is affected by that. For some, the blood pressure goes up. That's white coat effect, and their blood pressure outside of the office is much lower. For others, it's the exact opposite. They have normal blood pressure when they go in an office, or lower blood pressure than they have when they're out in the real world. And we don't know why these things happen, but we know they can significantly impact the accurate diagnosis and assessment of blood pressure if you're only using office blood pressure. So the idea that high out-of-office blood pressures are associated with increased cardiovascular risk independent of office blood pressures is really important. And out-of-office blood pressures are a more accurate predictor of future heart attacks and strokes and death than office blood pressures, than routine office blood pressures. So this is why SMBP is so important, self-measured blood pressure monitoring, and one of the reasons why this paper was written to try to increase the use of self-measured blood pressure monitoring. Next slide. So the evidence that's reviewed for the indications for self-measured blood pressure monitoring really go back to the 2017 ACC/AHA guideline and evidence review, where there was very strong recommendations, 1A recommendations, the strongest recommendations you could have to use out-of-office measurements to confirm a diagnosis of hypertension and for titrating treatment with BP-lowering medications in conjunction with telehealth counseling or clinical intervention. So this grade 1A recommendation is for confirming a diagnosis and for titrating medications, for treating hypertension. And this is the first time this level of recommendation was given in a clinical practice guideline in the United States. And then I think often missed in this guideline was a graded 1A recommendation for using SMBP for monitoring as follow-up after a medication was initiated, and as one of the strategies for following up to lower blood pressure, being team-based care, home blood pressure monitoring, and telehealth strategy. So very important, strong evidence that's really nicely reviewed in this paper for why you should be using self-measured blood pressure monitoring. Next slide. So this is just a simplification. So now, you know, here we are in a pandemic, office visits have been reduced, telehealth has been scaled rapidly. And, you know, I think there were many that are advising and using home blood pressure monitors and self-measured blood pressure monitoring, but again, we are in contact with organizations across the country. Many don't know how to do this in a way to actually improve blood pressure control. It seems like you could just hand out a monitor and blood pressure could be managed easily, but that's not exactly the case. You know, and that's one of the things we want to talk about. So SMBP can be used to confirm a diagnosis of sustained hypertension based on prior high office blood pressures or high out-of-office blood pressures. It can be used to detect white coat hypertension and mast hypertension and resistant hypertension. So there's an indication for all of those things, very important, and to assess blood pressure control and the effectiveness of treatment and changes in treatment. So also very important there. It's also been shown to engage patients in self-management. So when it can be used, especially in a situation where we're doing mostly virtual visits or many virtual visits, so before or after a scheduled encounter, whether that's a telehealth encounter or an in-person encounter, either, after a medication or treatment change of any kind, and really at the discretion of the clinician to assess blood pressure control for blood pressures that seem to be up or down or inconsistent. Very important to have that option and to be able to do it so it has meaning. And we're going to talk about what needs to happen for that to be an accurate way to assess blood pressure. And who does this? Well, this can be done by physicians. It can be done by any providers, nurse practitioners, PAs, pharmacists. There's good evidence that's been demonstrated for all of these ways, again, in a team-based approach. And of course, patients really benefit the most and obtain their own data. And this is patient-generated data is extremely important. We're learning more and more about what patients prefer in this process, but extremely important. Next slide, please. So from a technique standpoint, you've heard me talk about this if you've been to this before many times, the importance of blood pressure measurement technique, and this is true for self-measured blood pressure monitoring. Recommendations that are reviewed are that you need an automated upper arm device, automated meaning it inflates on its own and deflates on its own. That would be preferable. Appropriately sized cuff. Miscuffing is still a leading cause of inaccuracy in blood pressure measurement, whether it's in or out of the office. Patient preparation and positioning, you can see from this graphic that we have here that's from the Target BP website, the importance of preparing, positioning patients, and then having an evidence-based monitoring schedule is important. Now, we've reviewed all of the evidence and used the monitoring schedule that's recommended in the 2017 ACC/AHA guideline, and that's consistent with most of the guidelines around the world for measuring blood pressure. We'll talk about that a little more. Typically, twice a day for 7 days with a minimum of 12 readings, but that evidence is there. We're not sure that that's the only monitoring schedule that will work, but that's been the most studied, and that's why it's recommended. I think TBD, with so much monitoring going on in the real world right now, we may find that in other studies that are based on what's happening now, there may be a different schedule coming. But for now, most of the evidence sits with this schedule. Next slide. So confirming device accuracy, using a device that's been validated for clinical accuracy is extremely important. And this is something that was, again, brought up first in the 2017 guidelines, and now publications around the world, including the World Health Organization, are calling for using blood pressure measurement devices that have gone through an international validation protocol. There are some ways for devices in the United States and around the world to get on the market without having been tested for clinical accuracy. And this is something that the World Hypertension League, the World Health Organization, the Lancet Commission on Hypertension, many organizations around the world and many countries around the world are trying to fight this, so that because a majority of blood pressure measurement devices on the market globally have not actually been tested for accuracy, which is obviously a problem. So in the United States, until April 20th of this year, there hadn't been a list where providers can go. Again, you've probably heard me talk about this coming. This is 5 years in the making, but this is a US blood pressure validated device list at validatebp.org, where it doesn't contain every validated device in the United States. It only contains devices where manufacturers submitted the data to be independently reviewed by an independent review committee that decides what meets the criteria for being on the website. But validatebp.org is live, and it's a very useful resource for clinical teams and patients to use to learn what devices are accurate and reliable. Now, currently, there are several international device lists that are more extensive, but they don't always cover the models in the United States. But I've listed them here in case your device is not listed on the US device listing currently, and you want to see if it's listed in one of the other countries, in which case it would probably be a validated device. Next slide, please. And again, we can take questions at the end. I'm trying to get this through this as quick as I can so we can get to questions. But how effective is SMBP for lowering blood pressure? And again, you heard me say at the beginning, you can't. It's not just about having a monitor and somebody randomly measuring their blood pressure and you expect their blood pressure to go down. But when properly used, SMBP is associated with significant lowering of blood pressure and improving of blood pressure control, but it's got to be coupled with feedback of those measurements back to the care team, to the clinical team, individualized counseling, and other adherence strategies. If that's done in the most comprehensive, most recent systematic review performed using patient data, you can expect the mean reduction in systolic blood pressure was 6.1 millimeters in blood pressure, and then significant improvement in blood pressure control rates as well. So this is again, it was a 1A recommendation in the guideline. This is about the effectiveness of a half-strength medication that you see from using home blood pressure monitoring with clinical counseling, again, patient education, and web or phone support. So we call these co-interventions, and SMBP with co-interventions, you see an average of 6.1 millimeters of drop at 6 and 12 months. This can be double or even triple if you've got a pharmacist, for example, managing or leveraging other providers. We've seen examples where this has been even close to 4 times as high as far as the drop in blood pressure goes. So 6 is the mean from the studies that were produced at the time a couple of years ago, but very effective when done properly. That's the takeaway. Next slide. So cost effectiveness is something I'm not going to spend a lot of time on. It's one of the largest sections of the paper. This is a policy statement. What I'll say is that SMBP is cost effective compared to office blood pressure monitoring. One of the problems that we have is that most of the studies for cost effectiveness are simulation modeling and haven't been done in the real world, and the ones that have really focus more on management for those already diagnosed, but there is a potential huge benefit for correctly classifying patients as either having white coat hypertension, sustained hypertension, or masked hypertension. And so we need more studies to focus on the diagnosis of hypertension to check for cost effectiveness, and we don't have those yet. Hopefully more to come soon, something we're working on now and several people across the country are. Next slide. So there's a really nice section in the paper on barriers to widespread use, and these are in the form of patient perceived barriers, provider barriers, and health system barriers. And I think this is really important because even when you try to do this well, you've got to be aware of the barriers so you can try to overcome them. So the patients perceive that having to measure twice in the morning and twice at night for a week is very burdensome. One of the problems there is that they think that that will be indefinite. They don't understand potentially that would be for a week after a change in medication or to make a diagnosis, and there wouldn't necessarily need to be frequent monitoring for the next 3 weeks after that until a full series was going to happen again. So in the 3 weeks between monitoring twice daily, you might see somebody monitor once or twice a week if their blood pressure is adequately controlled, mainly for engagement. And even if it's uncontrolled, mainly for engagement until the next change in intensification or until that change kicks in. Also, there's there's concern on patients that they don't understand the benefits or how to achieve the benefits or why. That's something that patients talk about all the time. And then, of course, probably the biggest out-of-pocket cost for devices. We know in Texas there is some coverage, but we need coverage for everybody, and it's something that the AMA and AHA are working hard for with our advocacy teams to try to come to a quick solution, especially now, to get everyone who needs a home blood pressure monitoring device to be able to have one. For provider barriers, well, that's, providers are concerned that there is not accuracy in the use of these devices at home. They don't trust the measurements, and so we need to do more about education and, again, promote the use of validated devices. They're also worried about a low adherence to monitoring schedules and the impact on staff time and increase in provider workload, that perception from interpreting these blood pressures. Of course, there's ways around that, but that is a primary concern that we hear about, again, all the time, but it's well documented in the literature as well. And then a lack of reimbursement for device purchase for them to purchase devices for loaner programs and for patients to have to pay for their own devices. And finally, health system barriers, lack of systems to transfer home blood pressure numbers or home blood pressure measurements automatically back to the care team, which is a requirement to do this effectively. Whether it can be done on a written piece of paper, but it's much better if it can be done through technology. There's often a lack of infrastructure for that, as well as automation in having systems in place to interpret those numbers and communicate results and interventions, leveraging many parts of the healthcare team across the health system, including having registries for this that don't always exist. Next slide. So very briefly, we've talked about this a little bit last year. These codes are now live. So these are 2 new SMBP codes for 2020 that are CPT codes for using self-measured blood pressure monitoring. These were approved in the CMS coverage determination, went live in January, and right as we started to promote their use, COVID-19 hit and many changes were made in coverage and reimbursement as a result of the public health emergency. But the first code is for care teams to train patients on using a validated device, education and training using that device including device calibration. And this can be submitted once per device. The reimbursement is about $11 from CMS for Medicare patients, and typically private payers do start reimbursing for these codes once CMS does for Medicare patients. But TBD, because we're so soon after they were approved and we haven't seen a lot of use, again, as the pandemic hit right around the same time. The next code on the next slide is 99474, and that's for managing patients. And this is a $15 a month recurring CPT code that you can submit. And it may not seem like a lot, but this is separate from a face-to-face encounter that you could bill for, or a telehealth encounter. This is not meant to be for a face-to-face encounter and replace an E&M code, but this is for having a minimum of 12 readings during the measurement period that you can average, document in the chart, and have somebody on the care team communicate a plan back. If you do that, every month you can you could submit this code, and again, typical reimbursement's about $15. Most of the work can be done by the care team. The physician or provider needs to document that they've seen the results and document a plan. Next slide. So we've created some resources to make that easier. We've got them on the Target BP website. Allison will talk about that in a few minutes because I'm coming up on time. And we've also created, I just thought I'd throw this out there, the AMA put out some special CPT codes during the COVID-19 public health emergency. I put this here for your reference in case you want advice on telehealth monitoring and how to use these SMBP CPT codes with telehealth codes. So these are useful resources. Again, some of many that we'll show you in the next few minutes. Next slide. And this is something we could talk for an hour about, but I'll save it for the Q&A. Every year that I've spoken since I started coming here in 2017, we've talked about the HEDIS measure being the only high blood pressure control or controlling high blood pressure quality measure that accepts home blood pressures. But now things have changed this year in that NQF18, CMS 165, which is also the UDS measure, and MIPS 236, which is related to NQF18. All of these quality measures, in one way or another, now will accept home blood pressures and home blood pressure monitoring that needs to be done in a specific way that we can talk about. All but HEDIS require a remote monitoring device that digitally stores the measurement and then transmits it to the provider, or for viewing, secure viewing by the provider on a third-party portal. HEDIS, which had done that for years, has now backed down to say that any patient-reported blood pressure is acceptable. So they've gone in the opposite. They've led, NCQA uses HEDIS as its leading quality measure to make changes to, and because of the COVID-19 pandemic, as of July 1st, they've taken away the requirement for digitally stored and transmitted, and now are back to taking patient-measured blood pressures, patient-reported blood pressures, I should say, and those are able to be put into the vitals field of the chart now, according to NCQA. The others have now moved into taking home blood pressures, but they need to be digitally stored and transmitted. We can talk about that in the Q&A if you have questions. Next slide. We're just about done here. So just leaving you with a final thought before we go to questions. And this is from that systematic review that I mentioned, that is the most recent, that showed that about mean of 6 millimeter drop if you use SMBP with co-interventions. And this is from the conclusion that it basically says that self-monitoring alone is not associated with lower blood pressure or better blood pressure control. But if you use it in conjunction with co-interventions, titration of medications by physicians or pharmacists or patients, and education and lifestyle counseling, this can lead to significant BP reductions which persist at least 12 months. And the more intense the co-intervention, the better the improvement in blood pressure. And so that's it. Next slide. We do have, I'm going to turn it back over to Allison. So when we started to see office visits disappearing during the pandemic, we moved very quickly to try to create some guidance for mainly primary care physicians, but anybody who is practicing virtual medicine that needed to understand how to use SMBP effectively. So we created an SMBP quick guide to just sort of, it's fairly comprehensive. It's 4 pages long, but it can be read very quickly. And this is a resource that's available to you along with all of the Target BP resources that Allison will briefly review now. And then we'll get to questions. Just take a minute on this.
Mike, thank you so much. I really appreciate that overview of the new policy statement. While Mike takes a deep breath and you all pose questions for him in the chat, I want to highlight a few additional resources really at warp speed for your future reference and sort of private review. If you could go to the next slide, please, and also keep going. One more. There we go. Thank you very much. I want to highlight the self-measured blood pressure quick start guide. We released this in May. You may have seen it in the Target BP newsletter, which is always your greatest source of new assets that are available. And what we tried to do here is curate all of the SMBP resources that were already on the website, some of which Mike mentioned today, including ways to assess your practice for its readiness to implement SMBP, some terrific training and education resources with CME credit, guidance on the codes that Dr. Rickatts mentioned, some tips on how to start and tools also to start a loaner program if that's something that will be valuable to the patient population that you serve. Further, also some training and practice tools to support staff in effectively equipping patients for success and training them to provide accurate measurement at home. And then lastly, some terrific patient education materials. If you go to the next slide, this is just an example of some of the things that are buried behind all the links on the Quick Start Guide, some of which you may have seen before. The example on your left is a checklist for staff to make sure they've covered all the basics and set a patient up for success. In the middle is just a screenshot of a short 3.5-minute video that teaches a patient in English and in Spanish how to self-monitor, self-measure at home. And then the other images, you saw the blue graphic that Mike mentioned before as a visual cue to support patients in proper positioning, and a model log in the bottom right there for patients to record their readings in an evidence-based manner in a way that will also support the SMBP CPT code recommendations. So those are all freely available to you on the website, and many more things. If you go to the next slide, I also want to highlight some specific detailed guidance. Dr. Rickatts touched on this, but it's the details around the new billing codes for SMBP and ambulatory blood pressure monitoring. So those are available to you and also linked to the Quick Start Guide. And then one last slide, which is new information in a collaboration that AHA and AMA have had with the National Medical Association and the Association of Black Cardiologists and the Minority Health Institute. We partnered around this year's Essence Festival, which was also virtual, but we launched a Release the Pressure campaign targeting African American women. And you'll see in those resources, if you go to the Essence website, an opportunity for patients to commit through a pledge and similar tools and resources to support patients in accurate positioning, a terrific, another instructional video that is a very conversational tone and maybe a great resource for the patient population that you serve. So let me pause here and really want to loop back in our remaining few minutes with some questions. The first I'll pose to Dr. Rickatts is really one about the role of pharmacists in self-measured blood pressure. The question was posed, sort of what role can a pharmacist play either in a clinical or a community setting? And I know later in the presentation, we're gonna have some other examples and perhaps in subsequent webinar events in this series, we'll dig into that a little bit deeper. But Dr. Rickatts, if you could just touch briefly on some of the examples that you've seen in the role that pharmacists can play in self-measured blood pressure.
Yeah, I'm happy to, Allison. I think that some of the best studies done that show some of the most effectiveness, biggest lowering in blood pressure involve pharmacists co-managing people with hypertension. So pharmacists, typically if they're embedded in a health system or a health center or practice, those are the most common for working with providers to co-manage high blood pressure. And we've seen across the country in FQHCs and in medical groups and some of the most advanced medical groups in the country, pharmacists are actually managing hypertension, overseen by a physician at some point or a provider, working together collaboratively. But the pharmacist is the one who sees the SMBP readings, processes them, averages them, and then communicates a plan back, with a potential sign off on any medication changes. So protocols exist, and this is being done across the country. So I think it's very extremely effective, and I've seen in some studies between 15 and 25 millimeters of mercury of lowering of blood pressure across the intervention group from having a pharmacist titrate medications. This is how you've heard of Ron Victor's barbershop study. The most recent one was done by pharmacists. They were actually in the community, but they were managing hypertension. They were using community obtained blood pressures in barbershops, but same concept, they were actually managing the patients with supervision from physicians. So it's extremely common with a health system pharmacist or an FQHC embedded pharmacist or primary care pharmacist. It's not as commonly seen with community pharmacists in retail pharmacies, but where they have collaborative practice agreements with physicians, that then it can happen. And that's something that we do see. The CDC has a whole guide about collaborative practice agreements in different states for physicians practicing with pharmacists. So something to look into relating to hypertension specifically.
Great, thank you very much. I think we have time for 2 quick questions and answers. One quick question, I think, is, can you, if a device is not validated, how would a provider know if it is, if it's not on the listing, I should say? And
Yeah.
then a related point is, can you use the CPT codes if you're using a device that is not yet validated?
Yeah, so those are both great questions. So I'll answer the second one first. The CPT code specifically says the device needs to be validated, but doesn't define what validated means. I've explained what that is, but so the intention is that CMS does not want to pay if a validated device is not used. Now, it doesn't have to be on the device listing to be validated. You can use, and this goes into the first question, if the device has been validated in other countries, and for whatever reason the manufacturer just didn't submit data, and you can email the validated device list in the US, you can email questions about whether or not the machine that you have has been validated and just isn't on the list for some reason. And there are dozens and dozens and dozens of those. For comparison, in Europe, there's over 100 devices on their validated device list. They've gotten much more cooperation with manufacturers. In the United States, we've solicited all the manufacturers, but only a handful submitted data on that. So yes, you technically do need to use a validated device to submit those codes, but the validation for the device doesn't necessarily need to come from the VDL alone, although any of the devices on there are validated. If you can write in and ask if the device is validated or not somewhere else, they should help you, as well as there are many hypertension experts that are attending this meeting, and I put my email in. Some of you are aware of it and use it, but feel free to communicate with our team anytime. You'll get a copy of the slides and you can reach out with other questions. And Allison, you said you had one more question?
Yeah, one more quick question related to HEDIS and the role of patient-reported blood pressures. Does that need to be an average of multiple home readings for the HEDIS measure? I'm not sure if you can answer that off the top of your head.
I actually can, because I spoke with NCQA directly and asked that exact question, and with our advocacy team, this is a huge change. As of July 1st, and for all of 2020 measurement period and 2021, patients can report blood pressures. They don't need to be tied to an encounter anymore. So you don't have to have a billable encounter that they're tied to. So somebody can just tell you over the telephone what their blood pressures are, or a single blood pressure is. You, as the provider, this was also new, you can decide whether you want to use an average over 7 days, which is what's recommended, with a minimum of 12. But if historically, they only wanted the most recent single BP, even if it was in a series of 28 blood pressures taken over a week. Medically, from a science standpoint, the best thing is to use the average. And now what NCQA is saying is it's provider discretion, what goes into the record, whether it's an average or the most recent. Even though the language still says most recent, they're willing to let the providers decide what they put in. So it can be an average or the most recent.
Great, thank you, Mike. Unfortunately, you all have some terrific questions, and one of the beauties of this series is that we can take those questions and try to weave those answers into the way in which we design subsequent sessions and the time that we have on those agendas. So thank you for your terrific insights. There's been some terrific sharing of success as well. So you've given us plenty of fodder for future sessions. I want to thank Dr. Rickatts for your thought-provoking overview of self-measured blood pressure. We're going to switch gears and now hear from Joy Johnson, who is the Assistant Director of Community Outreach for the Northeast Texas Public Health District. Joy is, as I said, the director, and where she supervises a group of community health workers, and together they work to make free chronic disease prevention and self-management services accessible for high-risk individuals in Northeast Texas. I know one of the questions in the prior chat was about the role of social determinants and how that may factor into the delivery of self-measured blood pressure care. So I suspect Joy may touch on some of those very points. So Joy, I'll now really look forward to hearing how you have operationalized self-measured blood pressure in your implementation efforts and strategy, and how they may have been impacted by COVID-19. Joy, if you could unmute yourself and turn your camera on, the virtual stage is yours.
Hello all. So thank you, Allison, for that introduction. I'm very pleased to be joining you all to share the work that NetHealth is conducting for improved hypertension control in East Texas, utilizing SMBP. Next slide, please. Next slide, please. Thank you. So the sharing topics that will be included in this presentation includes an overview of our Center for Healthy Living. We'll talk about SMBP activities and how we've carried that out, the operational aspect of it. We'll also talk about our work with stakeholders and my role as co-chair of the East Texas Regional Collaborative. We'll talk about what providers can do to support the provision as SMBP and give some ideas to help with maybe the costs associated with it. And then lastly, if we have time for questions, we can do that. If not, I will provide my email address, so feel free to reach out to me. Next slide, please. NetHealth Center for Healthy Living opened in 2013, and it's the site of a former fire station. It is staffed by a team of community health workers and health educators. The purpose of the Center for Healthy Living is to provide free health services for prevention and or management of chronic disease. Next slide, please. There are 5 full-time community health workers who all perform a variety of duties, such as service coordination, navigation, health education, and even physical activity classes. They're involved in a variety of different projects, and that includes free biometric screening, which means that anyone in the community can come to our center regardless of insurance status and receive a free blood pressure, cholesterol, and glucose test. As I said, they're involved in numerous projects, but the project that we'll be focused on is their role in SMBP support. Next slide, please. Oh, and before you go to the next slide, I'm sorry. With COVID-19, obviously, many of us have had a shift in duties and roles, and we're no different. So one of the things that we have shifted to is the implementation of a COVID-19 community triage and call center, where anyone in the community can call and be connected to a testing site that works best for their financial needs. So that is the role that we're also playing in addition to the other projects. Okay, now next slide, please. Thank you. So in our hypertension and cholesterol management activities, it really is divided with 4 quadrants, and that includes community screening, the SMBP project itself, along with community collaboration and primary care navigation, which is a key part of being able to have SMBP success. Next slide, please. So as many of you are aware, community outreach is a big part of what we do. And for Net Health, the purpose of community outreach is one, to raise awareness of our programs, and the other is to screen for chronic disease, in particular high blood pressure. We found that many people are walking around with significantly high blood pressure that either they have not been diagnosed for or they're not being adequately controlled. So that is a primary purpose. We do numerous outreach events per year, or we did pre-COVID, and that included community health fairs, employee health fairs, or workplace interventions, faith-based events. And we've really had to get creative in how we reach our target population. So what we found is that health fairs don't really give a high turnout as far as people getting into our classes, or there's not really a good return on our time investment. So instead, we focused on where our target population frequencies and how can we go to them. So that led us to go to bus stops. We have set up a tent at a bus stop in the middle of summer in Texas, and we do blood pressure checks as they're waiting for the bus. Another thing that we do is every year we partner with other organizations, and we go to a local barbershop where we do blood pressure readings for free on a Saturday. And that has been a very effective tool, especially since we know that men are less likely to go to a primary care provider, and it's been very effective for us to be able to reach that target population. Other places are bus stops and laundromats and grocery stores. So just get creative on where you go to target your for your target population. Next slide, please. So our enrollment in SMBP has a certain eligibility. So a person has to have a blood pressure reading of 140/90 or above on 2 subsequent readings. Another part is that they need to be willing to commit to a 12-week cohort. They also need to be willing to log their daily readings and then be able to provide those to us. Ideally, we would want them to call us. However, in the past and with this last cohort, we have had to reach out to them. So how they are, after they are found eligible and willing to enroll, we invite them to come to our center where we perform another blood pressure reading, and then we fit them with the most appropriate blood pressure cuff. We then give them detailed training on how to check their blood pressure at home. We provide them with a toolkit, which involves, of course, the monitor. We also give them education. So there's a book by DSHS on hypertension control. So they're provided that, along with a booklet on logging their daily readings. We also have extra batteries in there for their monitor, as well as contact information with their assigned community health worker or pharmacy student, and our contact information should they have any questions. And the incentive for them to enroll is that they get to keep the blood pressure monitor, which is different from previous cohorts where we just said from the get-go, this is your monitor. And we had a lot of people that dropped out and we were not able to retrieve those monitors. Next slide, please. So here are the results of our most recent cohort that was analyzed by the epidemiology team for chronic disease at DSHS. And the cohort was for last year. It went from June to November with a staggered enrollment. And we had 29 out of 32 participants who completed the 12-week SMB project. We were very specific and strategic in who we enrolled, since we have had issues in the past with people dropping out. So the demographics for this cohort was that 76% of them were overweight, more likely to be female with an average age of 54. You can see that at baseline, their systolic was 164 and their diastolic is 93.7. The completion average was 148.6 over 89.1, which indicates a significant decrease in systolic and diastolic at the 3-month mark. Next slide, please. So as Dr. Raycott said, home blood pressure monitoring in and of itself is good, but to be more effective, you do have to have an individualized, tailored support system or a team that works together with the individual. In our case, they were assigned a community health worker, which at the end of the 12 weeks, they had developed a relationship with the community health worker or pharmacist or pharmacy student. And even to the point where when they called our center, they specifically asked for those individuals that they preferred to talk to. Not only did we have that relationship with the individuals, but we also had an opportunity to determine what their barriers were and what their social determinants were. So we conducted a brief assessment. Do you have a primary care provider? Are you uninsured? Do you need help with housing? Do you need help with your utility bills? Do you need help finding a job? So we really were extensive in how we approached them, as well as, do you have other chronic diseases that you may want to manage as well? And we invited them to attend our diabetes education classes. So as you can see in the study that Dr. Raycott's mentioned, it was a meta-analysis and involved over 10,000 patients, and there was a slight decrease with no support, but really it was that additional support that really made a difference. And it really goes back to that accountability. As a matter of fact, we found that when we do follow-up, the participants particularly missed that weekly call and advise. And so that's one of the things that you need to keep in mind when you're implementing SMBP. Thank you. Next slide, please. So this is a busy slide. It has a lot of information, but to sum up, one of the things that we really wanted to do when we implemented our hypertension project is to create a collaborative where we had stakeholders from various organizations that came together and talked about how we can improve hypertension rates in Smith County, East Texas. And it included a mix of physicians, nurses, CHWs, social workers, various public health. We even had paramedics that come. And everyone was so appreciative of being able to come together and discuss through some topics and have some shared goals. One of the things that we talked about extensively is that disconnect between pharmacists and physicians. We actually had 3 physicians in the room and 8 pharmacists at one point. They really talked about basic issues like, how do we get feedback? How do we get advice or suggestions to physicians on the pharmacy end? And physicians were very receptive. However, through the process of everyday office work, there was that disconnect. So we're working on a joint agreement that would allow them to be able to collaborate better. So that's one of the things that we're working on, as well as the promotion of MTM, really the awareness. There were many people in the group that were not aware of MTM and the challenges that go along with it. So the pharmacists were able to share some information. And one of the other things we wanted to do is standardize the way that hypertension checks were done in the community by various organizations, because they can vary significantly. Our accomplishments was just being able to get everyone together to discuss through these issues, to come up with shared goals, and eventually our collaborative was invited to become the East Texas Regional Collaborative for the for AHA, sorry. Next slide, please. So I'm not going to go into too much because I felt like Dr. Raycott's really covered this really well, but I encourage providers to check out the quick step guide and really to understand the value of SMBP, to then decide if you want to implement it or if you want to find other organizations that may be implementing it that you could partner with, and that way you guys can share in that role. Another thing is just to empower patients on your end. One of the biggest issues is getting enrollment, having patients commit to that 12 weeks. And if they are shown the value of it on the physician side, they are more likely to enroll. Patients want to decrease their blood pressure. It's just a matter of getting them to commit to that goal. And again, we want to encourage more coverage of SMBP. And I wanted to touch really briefly, I don't have a slide on this, but one of the things that we did, Net Health partnered with 2 libraries to offer a blood pressure lending library program, which meant that we provided blood pressure monitors to both of those libraries where patients could check it out along with the toolkit of all the items discussed earlier, and they could then use it for 2 weeks with 1 renewal, so they could have it up to a month. So that's something that you can think about, and it's a really cost-effective way for your patients to be able to have access to a blood pressure monitor without having to actually purchase one. Next slide, please. This is my contact information and our website. If you have any questions that cannot be answered today, feel free to reach out to me and I'll be happy to share with you. Thank you.
Joy, thank you so much for sharing the great work that you all are doing in Tyler and the surrounding areas in Northeast Texas. It's really a great combination of taking the evidence and then being very individual and community-centric in your approach. You answered a lot of the questions that came up during your remarks about social determinants screening, cuff sizing, and some of the important steps that you all are taking to ensure accurate measurements and success in your support model. I will ask probably in follow-up, maybe we can do 2 questions after the fact, one around the actual social determinants questionnaire that you use, and 2 on some of the cleaning protocols that you use to support your program. So I want to thank you again for your remarks, so that we cover the last section of our program before the top of the hour. I want to turn to Sarah O'Kane. Sarah is a healthcare information analyst for our outpatient quality efforts at the American Heart Association. And Sarah is really going to be concluding with one of our calls to action, and that's the importance of measuring our shared goals. The annual Target BP recognition allows you to measure and celebrate the progress that you make within your own organization. And it also provides a summary and snapshot of progress in hypertension control across the state, the 9 regional collaboratives in the Texas hypertension control movement. And with the September 4th deadline upon us, we wanted to take this opportunity to invite you once more to participate and hear some expert guidance. Sarah manages the operations of the annual recognition program and the outpatient programs, and oversees the technical development of the data platform. As a member of the American Heart Association's Quality Outcomes Research and Analytics team, she works closely with the AMA to collect quality improvement data and support the Target BP program. And before joining the new core team at AHA in late 2019, she worked for 5 years in AHA's development office, implementing more than 35 mission-driven events around Texas each year. Sarah, I would invite you to unmute yourself and turn your camera on, and the virtual stage is yours.
Thank you so much, Allison. Appreciate the introduction. So I won't reiterate, but I am Sarah O'Kane, and I really appreciate the opportunity to talk about recognition data today, since it's such an important piece of Target BP in measuring our progress and really recognizing those who are working so hard to control hypertension rates across Texas. So whether or not you're already participating in Target BP, you likely already have data about your organization's progress toward hypertension control. And regardless of where your rate is, that data is extremely valuable to us, because we really cannot know where we're going if we don't know where we've been. So as Allison mentioned, we are 3 weeks away from our deadline for data submission for recognition. So I just want to call on each of you, if you have not already submitted data, to take that next step and submit your data for Target BP. Next slide, please. We can go to the next slide. So the AHA and the AMA, we really want to recognize your commitment to improving blood pressure control and celebrate those achievements. When you submit your data, your organization will be recognized on either the participant or the gold level, and you'll receive a host of benefits, such as listing on our websites, a plaque with a medallion, inclusion in a national press release, and more. So last year, 97 Texas organizations showcased their commitment by submitting data, which is fantastic. And even with the shifting priorities of the pandemic, we have had 49 organizations submit so far this year, but we'd love to either meet or exceed that total this year. Next slide, please. So beyond just recognizing your hard work, your data helps us collectively inform our understanding of how our Texas participants are doing with hypertension control. This illuminates trends across Texas and its collaboratives, and it also illuminates the trends across different types of organizations and nationally to help us improve the program. Next slide, please. So we've covered the why, now down to the how. So the deadline to submit your 2019 data to be recognized this fall is September 4th. And that data includes information on your patient population, number of providers, breakdowns by payer, and demographics. And the main data that determines your award status is the numerator and denominator of the controlling high blood pressure measure, which is consistent with MIPS 236 and NQF 18. And that's what we determine, that's what we use to determine gold status. We're looking for organizations whose patient population have more than 70% of their population under control. So next slide. So there are 2 steps to submit data for recognition. And the first step is to register. This enables us to create a profile for your organization and a user login for you to submit data in our online data platform. So if you're new to submitting data, or you want to add additional organizations to submit data, please go to heart.org/registermyoutpatient.org if you have not already. If you have submitted data in the past and you already have a profile set up, you can just skip straight to entering data. You don't need to re-register year over year. And then I'll also note 2 quick things that 1 registration equals 1 potential award. So if you're a health system and you want all 5 of your individual clinics to be recognized individually, you will need to submit a registration for each of those clinics. There is a multi-site registration process within that link that you can use to save a little bit of time rather than filling out the form over and over again. And our process is the same for our other AHA outpatient recognition programs, check change control cholesterol, and target type 2 diabetes. So you can register for all 3 programs in one fell swoop and submit data in the same platform if you're participating in all 3. Next slide, please. So the next big step, and this is important because registration is not the final step. Once you get your user credentials by email, you'll head to our online data platform at aha.infusaria.registry.com, and you'll navigate to program forms, hit add new. You'll enter 2019 because the program is collecting data from the 2019 calendar year for this year's recognition. You'll fill in all the fields and save and exit. And so the deadline to enter and finalize all of that data is Friday, September 4th at 11:59 p.m. Eastern. The minute after that, that's when we take a snapshot of all the data that's in the platform, and that's what we use to determine everyone's recognition status. Next slide, please. And this is basically just to reiterate that it's a 2-step process. That's a preview of the registration form on the left, and that's a preview on the right of the actual data platform where you'll submit your data. Next slide, please. And this is just an FYI, we have a speedier way now for organizations to submit data for multiple individual sites in one swoop. It's through a self-service upload tool that allows you to type your data into a spreadsheet and drag and drop it into the platform, as opposed to typing out all the data for your multiple sites getting recognitions to save a little bit of time. So if you're interested in submitting through that way, please reach out to us at that bit.ly/AQ contact us link. That'll direct you to an American Heart Association staff member to help get you set up. Next slide, please. And this is just a quick preview basically of what the uploader looks like. So you can go to the next slide. These are just some kind of quick tips for success because we really don't want a technical glitch or a forgotten field to prevent you from being recognized this year. So just some quick reminders. Again, enter your data by Friday, September 4th. Earlier the better. If you're new, register early because it does take me a day or 2 to set up your profile for you to submit data. And then when you're entering data, We have plenty of resources with instructions, data collection worksheet, so make sure you're using those to make sure you're submitting the right data. And we do ask that you complete all the fields in all the tabs to be eligible. So that means don't leave any fields blank, enter a 0. And then just make sure everything's saved before that September 4th deadline. Next slide, please. All right, so I know that I can count on each of you to submit your data to be recognized and help Texas measure our progress. So these video walkthroughs and printable resources will take you step by step through the data submission process. So please be sure to check them out. And then don't hesitate to reach out to us if you have questions. I'll put my email address in the chat, and then that bit.ly/AQ contact us link is also a great way to get help before the deadline. Thank you so much.
Sarah, thank you so much for that quick walkthrough. You've made this process as painless as it can possibly be with all of your great tips and tricks and the resources that were on on this slide that you'll all get in follow-up to this event as well. I want to wrap up today in our remaining 2 minutes, but to thank everyone for your participation. And really, I want to specifically on the next slides thank all of the staff members from all of the sponsoring organizations that help plan and execute this event, and we're going to continue to press forward with the series of this fall. Again, your comments and questions along the day will help us plan subsequent events as well and layer in your specific concerns. I want to specifically thank our fearless leader, Heidi McPherson, and turn it over to her for the final few remarks of today's events. Thank you.
Thank you, Allison, and a huge thank you to each of the speakers and to each of you for being here today. Really appreciate it. Let's go to the next slide. We've got a couple of action items for you to recap. The first is if you could take some time, this link here will be put in the chat to provide feedback on the session of what's meaningful, what you'd like to see in the upcoming sessions. We've got 5 more to go before December. And then link to those of you who want to learn more about SMBP. There's a free CME course on the Target BP website. That link will also be posted there for you. And our partners at the Department of State Health Services have more resources on their site. If you're not familiar, there's that link as well. And then I invite any of you who aren't already a part of our regional collaborative network across the state of Texas to contact me. Go ahead and I'll put you in touch with each of the regional collaboratives so you can get connected to the conversations that are happening around the state. The more that we connect to what each other's doing, the more powerful our collective work is. Really appreciate all of you taking time to be here with us today and look forward to seeing you in upcoming sessions. The next slide, which is our final, has an overview of the topics that we'll be covering, and our next session will be held on September 22nd. Thank you, take care, and stay healthy. Bye-bye.
Say the truth every time you speak, without a doubt. Got everything I need. Yeah.